Well, welcome to the Let's Talk About Poop podcast, where I'm Dr. Islam, a board-certified gastroenterologist trained at the Mayo Clinic, and every week we do a deep dive into a topic concerning your gut health, so I can answer questions you guys have. If you're joining for the first time, I want to thank you for listening and watching. So here's how the format works. In the very first half of the audio, I'll go in the video. I'll talk about a deep dive into the topic, and we'll go into questions that I get about that. Basically 4 questions about that. And then towards the later half of the video, I go on my live stream to answer any questions people may have about their GI health and any information. If you want to learn more, or if you want to learn more information about me, myself, and my practice, visit us at LubbockGastro.com or come see us in our clinic in Lubbock Gastro in Lubbock, Texas as well. So I hope you guys are ready, and let's go and begin. So today's deep dive, we're going to be talking about IBS, irritable bowel syndrome. We'll talk about the causes of this, the symptoms, the treatment options, and also when to see a doctor about your IBS condition. So IBS is a very common disease. Millions and millions of people suffer from IBS, and the symptoms can range from diarrhea to constipation to a little bit of both, and sometimes we don't even know what some of the symptoms can be as well, including bloating, distension, reflux, and other associated symptoms as well. Now, it is a diagnosis that we can typically make when patients come to see us in the office. So for example, I have somebody come to see me, say, hey, Dr. Islam, I have diarrhea with some pain, and it gets better when I have a bowel movement. I can give you a diagnosis of IBS just with that. So there are a couple of critical things you need to know about IBS. So like everything in medicine, we have definitions for this, and we have ways to kind of characterize people based on their symptoms. So if you have IBS, one thing you have to have is abdominal pain. Abdominal pain of some sort is part of the criteria when it comes to IBS, whether it's pain with having a bowel movement or pain that gets better with the bowel movement, or you have a little bloating or discomfort, that can be considered pain. And with that, you also have to have a change in your bowel habits and a change in your bowel caliber as well, meaning you have a new change in your bowel habits, whether you're having a change in the shape, the size, or the frequency of that. It has to occur for a certain amount of time. That is the medical definition of IBS. And when we have somebody come see us in the office, we can actually diagnose patients with IBS based on their symptoms alone. Meaning, you're coming in for pain or bloating, it seems to get better with a bowel movement. That can give me a diagnosis of IBS. And there are a lot of different symptoms that can come from that. I talked about it briefly, but one spectrum is diarrhea. So you can have IBS-D, where you have diarrhea as the main predominant symptom from that. Then on the other spectrum, you can have IBS-C, constipation, where you have constipation as the main predominant symptom. You can also have IBS-M, where you have a mixed pattern. So you have both the diarrhea and constipation in the same patient, and sometimes even in the same day. And then lastly, you can have IBS-U, undefined, in which we really can't fit you into a category. These are the main symptoms of IBS. There's a wide spectrum of patients that can have those symptoms depending on the day. But there are other associated symptoms when it comes to IBS. So bloating, very common in my IBS patients. Sometimes you have reflux, very common symptom in my IBS patients. Sometimes feeling fatigue, very common symptom in my IBS patients. Sometimes you have headache, very common symptom. Brain fog. These are other associated symptoms that can come with IBS that can allow us to determine if this may be kind of what's going on as well. So you can have a wide spectrum of symptoms depending on the patient and depending on their presentation. So why do patients get IBS? This is a good question because we don't even know the answer for this. And it's a very common question that we're seeing right now. And it's an area of current active research. Here's what we know. So we know that there is some role between the brain and the gut. That's called the brain-gut axis. It is real. So a lot of what we manifest in terms of our symptoms, how we feel, or stress that we have, can actually be reflected in our GI tract. So if I'm stressed, I can have those symptoms reflected in my gut, and that is called the brain-gut axis. This is why whenever you're nervous, like you're doing a podcast, and you're nervous, you may have to feel the urge to use the restroom, or you're giving a big speech and you all of a sudden have, the runs with that. That's called the brain-gut axis. What we found in our IBS patients is that sometimes that connection between the brain and the gut may be overstimulated. You may have an hyperactive drive going on, and that can cause IBS symptoms to occur. A second theory is that it could be a change in your gut microbiome. We've seen evidence that up to 20% of our IBS patients actually have a condition called small intestinal bacterial overgrowth, or SIBO, which is very common, and this can occur whenever you have a change in the gut microbiome. So some of the strategies that we offer for our patients is offering a change in the gut microbiome, altering what they're eating, or actually giving you medications to change what's going on in the gut microbiome. Number 3 is a condition called leaky gut. So I know this is controversial, but there is some evidence that low-lying inflammation actually occurs in IBS patients, actual leaky gut. What is leaky gut? Well, normally in our gut, you have your cells that are tight. They're called tight. They have tight junctions that are there. And in some IBS patients, we don't know why, you have low-lying inflammation that can cause those cells to open up to cause seepage of bacteria, toxins, and material. And that can cause the condition called leaky gut. Now, leaky gut is not an actual medical term, but it's something you should be aware of because you'll see it very commonly in social media. And I suspect in the future, more research that comes about will give us more information for that. A next common reason is called visceral hypersensitivity, meaning the nerves in your GI tract are super sensitive. It's like fibromyalgia of the gut. The best analogy I give my patients is that sometimes the radio is turned on, but the volume's all the way. And some of the medications that we give you can actually help turn that volume down to make it a lot easier. Or it can be a combination of all of the above. Sometimes food can also be playing a role as well. And sometimes the foods that we eat can make IBS symptoms worse, and sometimes eliminating those foods can make IBS symptoms better. But the overall thing I want you to be aware of is that there's not one size fit all, meaning your reason for your IBS may be different from your friends, who may be different from their friends, and you may have multiple different reasons why you have IBS going on. And this is why it can be frustrating for my patients who have IBS to try things that their friends have tried, which did not make them feel better. And it's something you should be aware of as well. So when I have somebody who has IBS, what do I do? So first I want to try and find out which part of the spectrum do they lie in. And the way I do this is I ask them, what is your most predominant or concerning symptom? Because even if you have diarrhea, you may be more worried about your bloating. Or let's say you have constipation, you may be more worried about your abdominal pain. So I want to try and see if I can really tease out what is the most predominant symptom that you have. And the treatment modality that we do for IBS is a symptom-based treatment, meaning we try to figure out what those symptoms are and we alter our therapy for this. One thing I have to stress to my IBS patient is that there is no cure. There is not. I wish there was. I wish we had a cure. I can tell you, hey, this will fix your IBS. But currently in 2024, there is no cure for IBS. And if anyone tells you there's a cure, or if anyone tells you they can cure your IBS, they're wrong. They are lying because there is no cure. They may have done fixes to help them out, but in actuality, there is no cure because we don't know the true cause of why you have IBS. So we would do what's called a symptom-based diagnosis. So we focus on the symptoms and try and see what we can do. So for somebody who has diarrhea, this is where food can actually play a role. We know that the best diet when it comes to IBS diarrhea is called a low FODMAP diet. FODMAPs are certain carbohydrates that are known to cause pain, bloating, and diarrhea. And the evidence we have for this is that it can work, but it only works in about 50% of our patients, meaning the other 50%, it doesn't work. Now, if you want to try and do a low FODMAP diet, you always need to get the help of a nutritionist because it is a very restrictive diet. And what we have found is that there are two main complications with being on a low FODMAP diet. Number one is that you can actually develop nutritional deficiencies. This has been shown, and this can be very scary for a lot of our individuals. But also more importantly, what I see is that a lot of my patients who are on this diet actually have a lot of food restrictions that they're putting on themselves, which can make them eat nothing, which is what we don't want. And so we always recommend, if you're going to go on a low FODMAP diet, to always have the help of a nutritionist. Now, some things that you can do right now: avoid dairy, avoid artificial sweeteners. These things actually help out. And for some individuals, avoiding gluten can be helpful because it is true that you can have gluten issues. It's also very true, sometimes avoiding that gluten can make you feel a lot better as well. So try and see if that can help out with that. Sometimes we may have to give you prescribed therapies depending if what your symptoms are, and also depending if you have your gallbladder or not. We have a lot of new therapies for that. That's the kind of the approach that we do for IBS-D. And there are some supplements we can recommend, including things like L-glutamine, collagen, which has been shown in some clinical trials to help out. On the constipation side, I will tell you my experience is that diet does not help out as a first-line therapy for constipation. We need to get you going and flowing first, because without that, we're not going to be able to get you to have better bowel habits. So my goal when it comes to constipation is to get you going. get you flowing. Do that first, and then we can introduce a diet later on. So sometimes we'll do things like consistent Miralax, or sometimes magnesium. Adding fiber will help out. Sometimes adding, and if that doesn't work, we have a lot of effective therapies for IBS-C to get you going and flowing. Once we've done that, then we can start to introduce dietary options. Mainly, sometimes the FODMAP diet can help out, though the evidence is not really quite there. But also maybe a diet like a Mediterranean diet or more of a plant-based diet can help out when it comes to constipation as well. Now, if you have bloating as your main side effect or a problem, this is a very common problem that we have. And I'll tell you, bloating is a difficult symptom to treat because this is also multifactorial. I'll do a deep dive podcast on this as well. But bloating can be due to so many different reasons, and sometimes it's hard to tease out what the true reason is when it comes to bloating. Sometimes we may want to consider some supplements when it comes to bloating, like charcoal can work, or sometimes things like Gas, IB Guard, and sometimes other things like chamomile tea or peppermint tea can actually help out. Sometimes we can avoid some of the triggers like broccoli, cauliflower, apples, dairy products, artificial sweeteners, chewing gums. These are things that can help out. Or sometimes we're going to change the gut microbiome as well. But once again, bloating is one of those symptoms which is very hard for us to pinpoint. Now, the big question I get from a lot of my patients, hey, Dr. Islam, when do I need to see a doctor? Let me tell you the reasons to go see a doctor and come see us, where we specialize in IBS. So number one, you're having symptoms that are just bothersome. If your quality of life is impaired by your IBS, you don't feel good, you just don't feel like you're doing well, come see me. We'll figure it out. We'll see if we can do a deep dive to find out exactly why you're having issues. But the important thing is, do you have any red flags? Let me tell you what these are. Red flags are things that we learn in medical school that let me know, hey, something off, something different is going on. We need to find out what that is. There's something that's more than just IBS. So for example, if you have diarrhea that wakes you up in the middle of the night, that is never normal. And that is never part of IBS. It doesn't matter how bad your IBS is. Your diarrhea should never wake you up in the middle of the night. If it is, come see me. We can find out what's going on. Number two, you have bleeding. Any amount of bleeding is never normal. And don't ignore bleeding. Bleeding is a sign of something going on. Now, the most common reason could be hemorrhoids. That certainly is not that is certainly not the only cause. Let me tell you a story of a patient of mine. I had a young patient in their 30s. They're having kind of typical IBS symptoms, but they're having rectal bleeding as well. It was actually ended up being quite a bit. So because of that warning sign, we did a colonoscopy. And guess what this patient had? They actually had ulcerative colitis. Colitis as the cause for their bleeding and diarrhea. Not IBS, but colitis. And so if we would have ignored that, we would have treated their IBS, their quote-unquote IBS, and not gotten any better. And their colitis would have gone and continued and gotten worse and had the chance of going into cancer. So that's another warning sign. Another warning sign is severe abdominal pain. Now, pain is certainly part of the criteria for IBS, but not severe pain. You should not be having a tremendous amount of pain. If that is the case, something else is going on. We need to investigate. Significant weight loss is another warning sign as well. IBS should not cause you to lose weight on your own. And so if you're having weight loss, especially unintentional weight loss, we need to get to the root cause of what is going on and hopefully get that taken care of you as well. Another warning sign is having a new diagnosis of IBS after the age of 45. So having a change in your bowel habits after the age of 45 is not normal. And that could be a sign of something bad going on. The thing we worry about is colon cancer. So if you have these warning signs, and they're not comprehensive, but these are some of the warning signs that we see. If you have this, come see me, come see a GI doctor so we can do a deep dive, find out what is going on, and hopefully get you taken care of. So this is my spiel I give to my patients who have IBS so we can do a full investigation to see what's going on. If you are suffering from IBS, come see us, Lubbock Gastro. We can find exactly what we can do to hopefully get you taken care of. And if you have any questions on that, put them on the live stream where we can kind of see what is going on as well. All right. Perfect. So a couple comments that I'm seeing. Hey, Dr. Islam, I have H. pylori. What do I need? What do I need to do for this? So a very common problem that a lot of patients have. So H. pylori is a bacterial infection that affects the stomach. That can cause pain, bleeding, bloating, distension, upset stomach. But the problem with H. pylori is that it can cause long-term complications, including an ulcer or even cancer as well. So if we diagnose them with H. pylori, there are 4 ways to diagnosis. One is the blood test, which we never do. There's no utility for that because once you've had H. pylori, it'll always be positive. We can do a stool test or a breath test, which are non-invasive ways to test for H. pylori. The problem with that, or the thing that's a downside with that, is that you have to be off of your antibiotics or in medications, and PPI specifically, and bismuth or Pepto-Bismol for at least 2 weeks before you can do this test. Otherwise, you're going to have a falsely negative test. And then lastly, we do an EGD, which is what I do, where I actually take a look and see what's going on and take biopsies from that. If you have H. pylori, we want to give you antibiotics to get rid of it. Now, I'll tell you, the antibiotics can be rough for some individuals. It can cause its own GI side effects: bloating, diarrhea, pain, upset stomach, indigestion. And so just kind of be aware of that. But H. pylori is a very common complication that can occur with individuals. If you're worried about this, come see us at Gastro, or come see me, where we can find exactly what is going on and hopefully do a deep dive to see what we can do to get that taken care of as well. All right, next question I'm seeing on the chat. Hey, Dr. Islam, I've been diagnosed with an anal fissure. What does that mean and what do I do? So an anal fissure is a literal paper cut in your bottom. Your bottom does not like to have any cuts that are there. And any small cut will become a big cut because it's so painful. Your bottom has so many nerves, fibers, and blood supply that any irritation there is going to make things worse. And when you have a bowel movement, that's going to make that fissure worse. So the most common presentation of a fissure is rectal pain. So it feels like shards of knife that you're pooping out, but also rectal bleeding as well. How do we diagnose a fissure? The best way to do this is to just do a rectal exam. So when I have somebody coming in for a rectal pain or rectal bleeding, I will actually do a rectal exam and see if I can feel that fissure that's there. And I will know pretty immediately, because that rectal exam, you'll be like, oh my gosh, that hurts so much. That automatically gives me the diagnosis of a fissure. So how do we treat this? Well, number one, want to keep your stool soft. So you want to have softer bowel movements, add more fiber, maybe add some Miralax or stool softener to allow things to go through a lot softer than normal. But also number two, we want to give you medication to hopefully help out when they have that spasm. So when you have a fissure, you have that tear that's there, your rectum wants to close off and spasm. As it's doing that, it prevents blood from going into the fissure to cause a scab to occur. So you need to find ways to relax that. So there are ointments that we can give you, whether it's calcium channel blockers or nitroglycerin, they'll actually allow that fissure to relax. Now, the important thing about taking these ointments is you have to take it for quite some time, 2 to 4 weeks at least. And even if you feel better, you need to continue using this to make sure it doesn't come back. This usually works, but in some resistant cases, we actually may have to have you see a surgeon to do a surgery to help relieve that. But more often than not, using the topical treatments can hopefully get your fissure taken care of and get you feeling better as well. If you're worried about this, come see me. We can find out what's going on. We can do an investigation, hopefully make sure everything's doing okay as well. All right, perfect. All right, guys. Another question here. Hey, Dr. Islam, I have chronic acid reflux. I take an acid medication, but it doesn't work. What is going on? All right, it's a great question because I see this all the time in my practice. Why do patients who have reflux don't respond to their acid therapy? So let me tell you, there are a couple of different reasons why. Number one is that you actually may not be taking your acid medication correctly. Here's what you need to know. For the vast majority of PPIs, you need to take this medication at least 30 minutes before your first meal. So get your first meal and know what it is, and know what time it is, and make sure you time your PPI at least 30 minutes before. PPIs don't work unless you take it on an empty stomach 30 minutes to an hour before your first meal. And so for the vast majority of PPIs, that's the case. But also number two, you actually may be on the wrong medication. You actually may not be having acid as a problem. So for my patients that have acid reflux, that are taking it correctly, but still having reflux symptoms, we will do pH testing. So we actually do a test to see objectively how much acid goes up, because what you are feeling may not be an acid issue, it may be another issue. And if by giving you more acid therapy, but it's not an acid problem, we're not getting you feeling better. So we'll do a pH test in which I can objectively see how much acid goes up, and I can determine, is it really an acid problem or is it not an acid problem? A third reason why you may not be responding is that you may be one of those people who may need surgical therapy to get their reflux taken care of. And once again, we could do a workup objectively to see if that's the case for you, so we can see maybe surgery may be the best option to hopefully get your acid reflux taken care of. All right, guys. Perfect. Well, I think these are all the topics I had for today. If you like what you hear, if you like what you see, don't forget to subscribe to my channel, subscribe to my podcast, like and share. And if you have any questions or any suggestions, let us know. I'd love to know what we can do better. I want to thank you for watching. I want to thank you for listening. Look forward to seeing you guys next week. Thanks and take care.